appreciate, you know, everybody just whatever. I got a couple people in taking that. But here's the lecture quiz. Let's see how you did on the lecture quiz. You ready? A and F. What does it stand for? Atrial natriuretic factor or peptide. Sometimes you'll see it as a P. It is released from the heart. It targets the kidneys, but it's released from the heart. Atrium is the heart. It is one of the chambers of the heart. So atrial natriuretic factor is released from the heart, and its function is to do what? Decrease blood pressure. You all know more than that. You know how it does it. It does it by targeting. It does it by targeting the kidneys to lose sodium. And what follows sodium? Water. So urine output would go up, blood pressure going down. Great. So you all do a lot more than was asked. So for this test that's coming up on the endocrine system, you know those things, right? So you can answer questions about it. PTH, you know what it stands for. What does it stand for? Parathyroid hormone's function is to increase blood calcium levels. Exactly. And you know how it does it. It targets the kidneys to conserve calcium. It targets the intestines to absorb calcium. And it targets the bone to break down. Okay. Erythropoietin targets. Erythropoietin is a hormone that is from the kidneys, and you would need to know it is predominantly from the kidneys, and it targets red bone marrow, right, Nicole, for the production of red blood cells. What else can you do So do we know why though? See, these are not to be punitive. These are so you know what you need to work on, right? So define anemia. What you say anemia is? It is a decreased red blood cell count. A decreased red blood cell count. That's what it is. Okay. Thrombopoietin is associated with what organ? The liver. It's released from the liver. Glucagon is released from the pancreas. The pancreas, it is the alpha cells, and its function is to do what? Its function is to increase blood glucose levels. Increase blood glucose levels. It does it by targeting glycogen. You need to know these hormones so well. Where they're from, what they target, what they're doing. Because most of these hormones are given as medications, and if you don't know what you're doing, some of them kill patients. Yes, they can. So you do need to know that. Define polyuria. Excess urine. Polydipsia. Excess thirst. Polyphagia. Excess hunger. Okay, so insulin's function is to do what? Decrease blood glucose levels. Can it do it so much that it'll take a person into coma? Yep. Yes. Decreased blood glucose levels is no joke. Insulin is no joke. Because when blood glucose levels start to decrease, a person will typically look like they're what? Sleeping. Guess what? They're not sleeping. Guess what they're in? A coma. And so guess what happens? Death. So insulin's a serious hormone. It's a serious drug that's given. And you got to know that when somebody's given insulin, you have got to be checking their what? Even if they're resting so comfortably. Right? Right? Right. Okay. Thymosin's target. Oh, y'all can't just think I'm straight up for that. They target T lymphocytes. That's exactly right. And you know more? You know what T lymphocytes do. Their function is to do what? Protect. Exactly. So I appreciate y'all being here this morning. And your bonus question is cortisol is released from the adrenal glands and the functions. But anyway, tissue repair comes with glucose neogenesis. But what is it doing to immune response? It actually is depressing the immune response. And people should know that cortisol is helping you in stressful situations for tissue repair to get through this stuff right now. But at the same time, immune system responses take a back seat. This is why when people are under stress, they produce cortisol, which is actually a very natural physiological thing to do. But if people stay under stress too long, what's compromised? The immune system. Exactly. All right. So guys, were there questions about the hormone? All right, look, guess what I found out while y'all were taking this quiz? Because we are supposed to go to the bathroom. We're supposed to go in this bathroom right here. So we're going to see if we can all stand in here kind of close. We're going to see. So anyway, maybe we can all fit in there. All right. Okay. Huh?
So at least we're all females.
Yeah. Yeah. Well, good point. Good point. So if there have been any men, I didn't even think about that. Thank you. You know, are y'all worried about me? Should be. So,
if it's an emergency, men can come in the bathroom too.
I don't really understand that whole thing. As long as there's stalls, right? Yeah. I mean, as long as there's stalls. But you know, I don't really get that, but yeah, thank you for bringing that up because I hadn't even thought about it. All right, look, so guys, we are essentially, we really had almost finished, but we really do need to make sure we look at these disorders because I hadn't gotten to talk to you about all the disorders. Everybody good? Okay. I think one of the hormones that y'all were doing in your little concept maps the other day is one of the hormones was Inhibition that I hadn't told you all about, but I do want you to know the gonads do produce, the ovaries produce estrogen and progesterone, don't they? Estrogen and progesterone, the ovaries do, in response to FSH. But the ovaries and testes both produce Inhibition as well. And you do need to know that it's from the gonads, and Inhibition suppresses FSH. So when I tell you it suppresses FSH, you should know, okay, what does FSH do? That initiates egg and sperm production. So Inhibition actually lowers it. So, because the fact is, if you get pregnant this month, do you need another egg next month? No. Now, has that ever happened? That there were two gestations with different ages? Yes, but it's rare because most people produce what? Inhibition. Women produce Inhibition. Men produce it too, and it's to keep their sperm count in check because some men are infertile because they have too many sperm. I know that sounds counterintuitive, but sperm should be approximately about 10% of a seminal, like per ejaculation, the seminal fluid, the semen, about 10% of that is sperm. The rest of it is going to be the fluids that help to nourish the sperm and keep the sperm healthy and alive and protect it. So if the sperm count is way higher than the proportion of the seminal fluid, then it can actually be a bad thing. And so Inhibition keeps the sperm count in check. In women, it suppresses an egg from being made. Okay. All right.
And you said that was the origin is?
The origin are the gonads, ovaries and testes. Okay. The origin is gonad. Okay, so we talked about that. And now I really do, and we had talked about these other organs. I hadn't given you all the things, but I gave you some, didn't I? Like calcitriol and erythropoietin are from the kidneys. Is that right? Calcitriol helps raise blood calcium levels by helping you to produce vitamin D, which is going to help with the absorption of calcium. It is from the kidneys. It kind of targets throughout, really, but it's really the skin. You get vitamin D, calcium absorption goes up. The erythropoietin from the kidneys. I don't want you all putting liver. I want you to put kidneys, okay? The kidneys is going to target red bone marrow so that the stem cells in the red bone marrow become erythrocytes. We said the liver produces thrombopoietin, which is a hormone that will target the red bone marrow stem cells to become platelets. Thrombocytes are platelets. You would want to know that. And they help with blood clotting. So we said it makes kind of good sense that if somebody has some beginnings of liver disease, they may have some blood clotting issues, and they may be bruising easily or more readily, and that could be a sign that somebody's liver is not doing quite what it should be doing. That made sense, we hoped. And then we said the liver and the kidneys and really even the lungs come together to produce a hormone that's called angiotensin. What was that hormone doing? What was its function? Yes, it's the most powerful vasoconstrictor we know, which means that it does what to blood pressure? Raises blood pressure, right? All right. And then the only other thing, the heart, we said ANF or whatever. I do want you to know about this group called enteric hormones. Enteric hormones mean that they're related to the digestive tract. Enteric. So what do you think these hormones are going to help you to do? Digest food and to help move food along, coordinate the motility. Because, after you swallow something, you don't have to think about it for 30 feet, do you? Until you get the urge to get rid of what you couldn't absorb. And that whole motility, all of that coordination is through these enteric hormones that are helping that happen. And we'll talk a little bit more about them and some specific ones when we get to the digestive system. Good. So, and we know there's others. Now, this whole hormone chemistry is FYI, which means are you going to be tested on it in here? No. It doesn't mean that you shouldn't look over it. You should. But I'm not going to test you on it. But maybe you've had some hints at this, that these hormones, they can be lipid-based. All the steroids are lipid-based. Are lipids good things or bad things? I've already hinted to you all. Lipids get a bad name because people think, oh, fats are bad. No, we have to have them. We said our plasma membranes are 90% fats, aren't they? But we have an entire class of hormones that are lipid-based. So people who are not getting enough fat in their diet, who do not have enough stored fat, could they be deficient in these hormones that are lipid-based? Yes, they could be. The steroid hormones, these are all lipid-based. Some of them are protein-based. So again, these major categories, proteins, lipids, whatever, we need to understand they need to be in balance. We kind of are what we eat, right? And so anyway, that's just FYI for you, but there it is, the chemistry of it, some of it. We talked about upregulation and downregulation, did we not? I talked to you about upregulation and downregulation and how this needs to be balanced because of this negative feedback. So we talked about the idea that sometimes it's not just that you're not producing the hormone or you're producing too much of it. Sometimes it has nothing to do with that. It has to do with the target cell's receptor response. So hormone disorders can be complicated, can't they? And even two individuals that had the same kind of disorder, hormone disorder, might have completely two different types of mechanisms that are causing the disorders. You get what I'm saying? So it can be tricky. And so we had talked about this. Now, I did want you to know that sometimes when we talk about the alarm reaction, when people are out of homeostasis, we said homeostasis could be defined as health, didn't we? Balance, staying within normal ranges. That's what we said homeostasis is. But anything out of that is considered a state of disease, right? So when we think about this and the body gets out of homeostasis, there's going to be, hopefully, a response to this. And I do want you to know there are three basic things that kind of happen. The first is called the initial response, okay? So the initial response is this idea that the body knows it's out of balance. And so the sympathetic nervous system, which is our what system?
is going to sort of take over. And what did we say people's vital signs are going to look like in this? They're going to be increased. They are. Respiration's increased, heart rate, heart contraction strength can be increased, blood pressure's increased. So that all makes good sense. So that is. And that's actually a good thing. It's what you would want to see happening, because if that's the case, then blood circulation is going to be getting to those tissues that might need them quicker. You know, and so this is actually a good thing that this is happening. Now, as that is happening, is that going to take more calories? Is that going to take more calories for the increased metabolism? Yeah, it is. And so glycogen was our reserve. And so we're going to go to glycogen, our reserve glucose. Do you remember glycogen is the reserve glucose molecule? So we're going to go and we're going to use that. And then actually, can it actually be used up? Yeah, we're also, blood pressure is going to go up because of aldosterone and angiotensin. These are going to help to keep the blood pressure up. We're going to be using more calories. Temperature is usually going to go up. Metabolism is going to go up. All this stuff's going to happen. And hopefully, we're going to, you know, in this next stage, we're going to try to get back into balance, right? So this stage of resistance is going to end up happening where all of the body is trying to heal or get over whatever what's happened. Now, if something doesn't change in this stage, the stage of resistance, if something doesn't change to keep you back in homeostasis, you can actually go into what's considered this next stage, which is a stage of exhaustion, which means that all glycogen reserves are done. You're now burning fats for energy. You've probably got a pH imbalance that you're trying to deal with at this point too. And so there's a whole bunch of stuff going on. And if medical intervention and or the body's physiology didn't get you back in homeostasis, what would eventually happen? Yeah, so this is kind of, these stages are kind of what we see in people who have terminal diseases such as terminal cancers or respiratory diseases like emphysema, which is a progressive terminal diagnosis. So, you know, these are the kind of things that go on. And, you know, some of them are very expected, right? All right. So initial stage of resistance, stage of exhaustion, these are just what we talk about. Now, I'm going to talk about some of these others. These are more hormones. Are they going to be coming your way in later chapters? They're going to be. So is that why we want to get the ones we get now? Because we're going to revisit these and we're going to be adding to our list. Y'all are thinking she has lost her mind. Okay. So guys, you know, we talked about the idea that we can synthetically make a lot of these hormones, and cortisol, I told you, we can give prednisone, right, and help people with tissue, give them a little boost of that with the tissue repair and whatnot. It's usually going to throw off electrolyte balance, and it's going to actually end up causing some issues with that. And so, you know, we try to really monitor and make sure that we don't keep people on these things too long. But anyway, and y'all got a little clinical insight about the steroidal anti-inflammatories and the non-steroidal anti-inflammatories. So definitely take a look at that insight, heads up, before this test on this. Some disorders, we talked about the idea that you can have a hyposecretion as a disorder, but a disorder just the same would be a hypersecretion. Isn't that right? I just heard somebody the other day, a friend of mine, saying that there was a tumor, that their friend found a tumor on one of the parathyroid glands. Do y'all know where that is? The parathyroid glands, there's 4 tiny little glands on the backside of the thyroid. And they're going to remove that particular gland because it was causing a hypersecretion. And did we say that tumors often cause hypersecretions? So they're feeling like as soon as they get to remove this little one, it's a little benign tumor, that it's going to be all right. You know, that probably blood calcium levels will come back down into normal range and then it would be okay. And because there's other parathyroid glands there, then it should just take over for it and be okay. All right, so we talked about diabetes insipidus, didn't we? Did we talk about acromegaly? We did, didn't we? We talked about gigantism. And maybe we talked about pituitary dwarfism as well, did we? So where you don't have enough growth hormone, and then you end up having sort of a proportional dwarfism in pituitary dwarfism. We had talked about a type of dwarfism called achondroplastic dwarfism, where that was a dominant mutation that just affected the long bones. And so you get a type of dwarfism where there's this disproportionate growth of bones. The irregular bones are normal size, but the long bones close off really early, right? This is different. And pituitary dwarfism, it's an overall effect, and so it's sort of a proportional dwarfism, right? Okay, and then this acromegaly, we said this young woman, this young girl, this young woman, is sort of normal progression, but then the hypersecretion happened in adulthood, so you can see how these irregular bones continue to grow. Now, thyroid and parathyroid, I do want you to know, I think I told you about goiters, didn't I? I said a goiter is not a diagnosis. It's just saying that, you know, somebody's thyroid is enlarged. And I gave you different examples. I told you about Hashimoto's thyroiditis, which is hypothyroidism. I told you about Graves' disease, which is what? Hyperthyroidism. They can both cause goiters. And I told you about endemic goiters, which is because of a lack of what? A lack of iodine. And this would be an example of an endemic goiter. And people don't wait this long anymore. I know, I don't know. I think this is from a long time ago. Or in areas where there's not readily available medicine, you know, available. So, right.
What did you say that one was?
Endemic goiter. An endemic. What'd you say?
As soon as you give that patient iodine, it will.
Okay, so yeah, you can give iodine, and the thyroid should decrease. If they have to, sometimes they remove them though. Like, I don't know what you do at this stage.
That's a little too far gone.
That's a little too far gone, maybe. I don't know. But actually, they do go down after treatments start. I've had a lot of students who get diagnosed with hypo and hyperthyroidism even during that's not so uncommon. Endemic goiters in this country are very rare. Why? Because we have so much salt in our diets, and the salts are all, you know, they put iodine in the salt, any sort of salt supplements that we have. And they do that for this reason, because we did see a lot of that. Now, adrenal disorders, you need to know these. You need to know these disorders. And I know you had them in your little concept things you were doing, and we hadn't gone to them yet, but now we have. So we're going to want to know these. The adrenal disorders, Cushing's disease or syndrome, Cushing's disease or syndrome. This is going to be either because of a excess of ACTH. And what does ACTH do? Where's it from? The ACTH is from the pituitary. So why am I talking about it right here? Because it targets the adrenals. And so the adrenal glands are doing their job. ACTH keeps knocking at their door, so they keep secreting, right? So the adrenals are secreting cortisol, secreting aldosterone, because they're getting the message too. So it's either because of an excess of ACTH, or it's because of a tumor of the adrenal cortex. So it can be for different reasons. Now, in little kids, y'all saw this the other day. Y'all were looking at it. I saw, in your book, you see what this little boy looked like 3 months prior, right, in a school picture, and then you see this. So you see this. I don't know if y'all have ever heard of prednisone. When somebody's put on prednisone for long periods of time, they are said to have a moon face. Have y'all heard that? It's actually called that. It's called like that prednisone face, moon face, because of fluid imbalance in fats over long periods of time will do this kind of deposit thing. Now, hopefully, what happens is after treatment, whatever the treatment ends up being, depending on what they diagnose, whether it was a tumor of the adrenal cortex or whether it was a tumor of the pituitary causing a hypersecretion of ACTH, this would kind of resolve over time, right? And go back. Now in women, and I say women because it's usually women in this that are older. When this starts in women, it can be much slower. Like this little boy, it happened quickly, didn't it? But in older adults, it can come on kind of slowly. And women will get what's called a buffalo hump, or fat deposition in the face. So I have to get with them and get permission for us to come. And so, yeah, it would not be, guys, until like probably exam week. Yeah, because that's just how it would work out, is that it would be late in April or maybe the first week of May even. But I am going to try to do that and see if I can get a group on there. Yep, I want to do it too. All right, so Cushing's is, so y'all would know, it's a hypersecretion of those adrenal hormones. And it's either because of a tumor there, or it's because of an excess of ACTH. So it's a hypersecretion.
Does that mean that there's a tumor in the pituitary gland as well?
It could be a tumor in the pituitary causing that hypersecretion. What'd you say?
Or, like, is there another explanation for the excess of ACTH besides the pituitary gland?
No, that's usually the answer for that. Now, okay, I hate these new notes. Okay, and then we also said that AGS, which is androgenital syndrome in little baby girls, is going to cause masculinized genitalia, didn't we? And what's going to, that's going to be a significant thing. And it's usually going to be pretty obvious when that's going on too, of these little girls. And I don't really know what the standard treatment is going to be for that. I think they've tried not just hormone therapy, but they also try, they have to do some surgical stuff as well. So, and now it can happen also in women. The onset can occur in women, and we had talked about that. Now, I also want you to know about, and this is so weird, they don't have it in here, but I want you to know about Addison's disease. Addison's disease. Addison's disease is kind of the opposite of Cushing's. Addison's syndrome is going to be, was that really not in the notes anywhere? Okay, so Addison's syndrome is going to be a hyposecretion from the adrenal glands. And because the adrenal glands themselves are not putting out the hormones they need, you actually, in this case, will also have an increase in ACTH. You will also have that, because the ACTH is trying to get the adrenals to work. But in this case, the adrenals are not doing what they're supposed to be doing. So in Addison's disease, the increased ACTH can also cause like darkening of the skin, because it's going to end up causing the melanocytes in your skin that give you pigment to become hyperactive. So it's like you're tanning, but you haven't been in a tanning bed, which you should not be in anyway. Okay, so, but you know how you'll know somebody might be darkening is that they are going to look like they're darkening, but there's no tan lines. Do you know what I mean? It's like all over darkening. In places where you usually see paler skin under clothing and stuff, everywhere is kind of darkening. They can also have glucose imbalances, because we know the adrenals play a role in glucose homeostasis, don't they? They can have electrolyte issues. So this is what's happening in Addison's disease. It's a hyposecretion from the adrenal glands. Okay, now,
Does AGS affect men too?
no, well, nothing that we know, because they have so much testosterone anyway, right? Yeah, no, so we don't typically, I've never heard of it. So diabetes mellitus, have I talked to you all about that? Type 1 and type 2, right? Now we also, we know some of this pathology associated with diabetes mellitus and imbalances in glucose. We know that people who can't use glucose for charging their batteries, getting ATP, are typically going to have to convert it first, carbs, to fats, and then burn fats for energy. So this just throws so much stuff off, including pH. Because as you burn fats, you are producing what are called ketone bodies, which throw you into something called ketoacidosis. And then the body's going to have to try to then hustle to figure out pH balances. And we have a lot of buffering systems in our bodies. We have our respiratory system as a major buffering system. Our kidneys are a major excretory system that helps with buffering. So does our digestive system, helps with that. But we also have chemical buffering systems in our body. But it puts more of a strain on that. And that can end up throwing off, again, electrolyte imbalances like potassium, which is one of the most dangerous electrolyte imbalances. And it just usually typically is going to cause the body to have to work a lot harder. So, you guys, there's some other types of diabetes. Y'all have heard of gestational diabetes, haven't you? What is gestational diabetes? The gestational diabetes is, again, an imbalance with this glucose, not being able to use glucose, but it's just during the pregnancy, isn't it? Gestational diabetes makes it a high-risk pregnancy. High risk for the mother, high risk for the fetus. Typically what happens is after delivery, and hopefully a safe delivery, that the mother and the fetus would be okay, but usually it resolves and it goes away, but it doesn't always. So some women who have gestational diabetes will become type 2 diabetic. And some women, and any woman who has gestational diabetes will be told that they're at a much higher risk of developing type 2 diabetes. Okay, so that's that kind, and we'll even learn about a different type of diabetes when we move on later, but not right here. Okay, diabetic neuro. Okay, so we had talked about the idea that high levels of glucose are neurotoxic. So keeping chronically high levels of glucose, when you eat a meal, your glucose levels can go above 100, 110 milligrams per deciliter. It's supposed to, because you just ate a meal. But the portion control is important because it will only take it a certain height, and then usually within an hour or so, you're back in your normal homeostasis. But people who never really get back to the normal, they're kind of staying chronically high. This is doing chronic long-term damage to the neurons and to the nervous system, which is then trying to coordinate with vessel control. So vessels can end up being damaged. The kidneys and how blood moves into the kidneys is not being controlled the way it's supposed to. So high blood pressure is typically a consequence, and high blood pressure typically, even a little high blood pressure uncontrolled for long periods of time, can actually destroy the filters in your kidney, which can lead to kidney, you're losing your kidney functions. So we had talked about all the possible consequences of uncontrolled diabetes mellitus, where you have neuropathies, cardiovascular complications and hypertension, renal complications with, potentially kidney loss of function. So amputations because of ischemic attacks. Ischemia means lack of circulation to the tissues, right? Ischemic attacks. So that can lead to gas gangrene, all those things. Now, I think we talk, hey guys, pat yourselves on the back. You just did the majority of the hormones. Charlotte did it. Everybody should do it. Pat yourselves on the back. Really. And now keep studying them. Don't ever think that, even after we take this test, don't think you're done with them, because you won't be. Yeah. Ischemic. Ischemic means lack of circulation. So blood is being impaired to get to the tissue. Ischemic attack. So like when you hear about infarction, do y'all know what infarction means? Yes. An infarction means a sudden loss of blood supply to the tissue. And usually when tissues have a sudden loss of blood supply, what are they going to do? Hurt. Well, there will be pain, but they'll die, won't they? So like a myocardial infarction is what people call a heart attack. And do those tissues die? Yes. Those tissues die. And infarction is like a serious ischemic attack. You know what I mean? A serious one. But ischemia means the blood supply is being impaired to that site. and you know, it's just it's not getting good perfusion. Yes.
With diabetic neuropathy or just diabetes in general, what about artificial sugars? So if you like use, I don't know, stevia or Splenda and you stay in that higher range, could you stay in that higher range and then it could cause
Diabetic neuropathy. Hey guys, I wish I'm going to just be so upfront with you all, and I really, really want you all to hear what I'm going to say, because we're about to we have one chapter during the digestive system. We talked about one chapter devoted to nutrition. And I think I've talked to you about this a little bit already. Anybody that you have that's a practitioner right now, and this is really ridiculous, and I fully accept how ridiculous it is and how I need to be doing more myself. But any practitioner you have, nurse, doctor, PA, I don't care what you do. There was one nutrition course required. One. And if your clinician is older, has had their degrees and whatever 20 years ago, none were required. Nutrition is we are understanding so much more about nutrition now, and so much is being discovered all the time about it, and how that instead of there being that one food pyramid, now there's 13 known different ones. How a person's blood type even affects their metabolism. It used to be thought calories in, calories out, you know, everybody was the same. Wrong. So much is ethnicity is influencing. So much stuff is going on right now about understanding nutrition that I'm going to just let you know that I'm completely ignorant. I can suggest to you some things that I'm just beginning to hear about, so you wouldn't want to use me as authority. But I can suggest to you about some things that I'm hearing about. But I would think, honestly, and I would really do this, if I were you guys, and especially going to be primary care providers, I wasn't nurses are the primary care providers. EMTs are paramedics are primary care providers. Doctors and PAs and most nurse practitioners, they're just diagnosticians. But if I were going, I don't mean just, but that's kind of the case. You guys are primary care providers and educators and spend the most time and are hands-on and touching, and executioners. Executioners. Yeah, I meant that, the way that it sounded. So if I were going into that, I would really feel it was my responsibility to learn more than one little class to teach me, especially because if the textbook's printed, it's already out of date about nutrition. Already out of date. I will tell you, you don't have to trust me because I've already said up front I'm ignorant. I will tell you that most of the stuff going out, being said, even about natural, the artificial sweeteners, that they're horrible for you. I haven't heard anything except that those companies who are putting out information saying that it's a better substitute, but supposedly not.
Yeah, because I think I read a paper saying that.
I've read I will say I've read several, and none of them are saying that any of this is good for us. And it's probably actually accelerating that. So, and I read some things that really sound like they're legitimate with maybe enough data to support it, that those, like, where's my Diet Coke? I wish I had. But you know, I'm trying to do less of it. But those artificial sweeteners, even some of the ones that say that they're, you know, or whatever, that they're worse than any, way worse, actually. So, you know, we have just gotten so used to things being sweet, you know, that when we have something that's like let's all admit it, how many of you eat instant oatmeal? Have you ever tried to just do the roll it? Okay, what? Like what? Is this the same thing? You know, we've just gotten so used to it that we just want things really, really sweet. And some of those artificial, the ones that are the alternate
sugar things are even sweeter, tasting and stuff to us. So I don't know. I don't know what to tell you about that, except that I think that there's a lot of information out there, so you can find that definitely. And I wish, and I really truly do wish, that there was more offered for people going into primary medicine. All right, so guys, congratulations. I really do think that we've got most of this endocrine out of our way. So guess what we get to start? We get to start the cardiovascular system. I'm going to give us a quick real break instead of standing around together in the bathroom. We'll give you all 10 minutes in a second. But what I'd like to tell you about is this cardiovascular system is really 3 chapters. First, we're going to talk about what's being pumped around, which is the blood, right? So hematology, the study of blood, bloodology, the study of. So hematology, we're going to study what this liquid connective tissue. It's a liquid connective tissue. We knew that connective tissues were a category all their own. And we said that one of the common features about connective tissues is there was a lot of extracellular fluid. Well, it's the same way in blood. Blood is a tissue, and it's got a ton of extracellular fluid. That extracellular fluid is called plasma, isn't it? It's called plasma. Y'all have all heard that before, haven't you? So we're going to study that first. Then we're going to see, and we understand that most of our cells are stationary. So because most of our cells are stationary, our liver cells can't move and go get the nutrients they need or go get rid of stuff that they try to get rid of. They're stationary. Our kidneys are stationary. Our cells are stationary. So they're depending on this liquid tissue, bringing them all the nutrients that are going to be necessary, but also removing any waste that are necessary. And so we're going to look at this blood, and then we're going to see how it's pumped. And then we're also, which is by the way. Right. And then we're going to see the vessels that this blood is being pumped through, right? So these 3 chapters. I want to remind you all that these first 4 chapters in A&P are the most complex that most students feel in the entire A&P 1 and 2 courses. So y'all are hanging with me tight for a couple of weeks here, aren't you? While we're getting this in, so that you really do get this well enough that you feel really like you own it. Because after this, smooth sailing. All right, let's take a quick little break and we'll come back. How about just 10 minutes and we'll come back? Okay, y'all can.
Ms. Banks, I do have one question.
Yes.
About the epinephrine, norepinephrine?
Yes.
So norepinephrine comes from the sympathetic, epinephrine comes from the adrenal, which comes.
Okay. So the sympathetic nervous system is actually going to be the nervous system that's innervating the adrenal glands to produce these epi and norepinephrine. It's sort of like me telling you about thymosin. Thymosin, I'm giving you a category because there are actually a couple of different variants of those hormones that just belong to that group, and I think that's all you'd ever want to know. It's just like estrogen isn't one thing. There's different types of estrogen. There's estradiol, and there's all kinds of, but they fall in this category of estrogens, right? So when I say epi, nor, epinephrine, they're really kind of 2 different things. Most of it's epinephrine, but anyway, just think of it as that, and it's from the adrenal gland. From the adrenal glands. Okay. All right, so let's go ahead and take a quick break. 1 week from today, which I have no idea what date that is, but 1 week from today, 26th, we will have at 9 o'clock a multiple choice test on just the hormones. Listen, everybody says, I don't think anybody is just 1 or 2 people here. Everybody says this is the most difficult chapter. If you are struggling, let me give you a heads up, a hint. You don't have to take it, but if I were you, I'd listen to this. If you are struggling, I want you, while you study from today till next Tuesday,
I want you to separate this information by organ systems. We started with the pituitary. And don't move past the pituitary until you know it so well you could go teach it. Don't move past it. If you think that you're studying by sitting there an hour a day skimming through all of the organs and all the hormones and all the disorders, you are probably hurting yourself. Don't study that way. Break it down and study it by organ until you know it so well that you think that you're probably going to take it to your grave. Living a long life, you're going to take it to your grave. You know it that well. Talk out loud when you study. It's proven to help. Then go to the next organ. Get its hormones. Where they target, what they do when they get there. Get those. Then go back and review the first one and the second one together. Then add the third one. You get what I mean? If you all don't time manage well between now and next Tuesday, it's going to come up and bite you next Tuesday. I'm just saying. Time management. You cannot study for this test the night before, the morning of, and expect to do well. The tests are multiple choice. The reason I do different types of assessment tools, like testing is multiple choice, but these quizzes are different types of tools, is because not everybody is good at all different types of testing. Now, multiple choice for some people, that's difficult for them. But for a lot of people, that's a better way for them to test. All right, so 1 week from today, 9 o'clock, a multiple choice test on just the endocrine factor. That same day, you will, before you take the test, you will have a picture, maybe a couple pictures of those 10 major endocrine glands. And would you be able to label them and spell each one exactly right? Would you? Okay, so you will do that at 9 o'clock. And as soon as you finish labeling 10 organs, you're going to start right in on that multiple choice test. Fair? Okay. Now, so, since you all, and I do think that was a wise decision to do it that way, break it up. I really do think it's a wise decision to do that. And it was up to y'all. But what I do want you to know is we're going to continue on with our study of the cardiovascular system. So on Thursday, I do want you to be prepared for a lecture quiz. And the lecture quiz on Thursday, I know you're going to have studied your hormones tonight and tomorrow night, but the lecture quiz on Thursday will just be on hematology, what we've covered in hematology. Fair? So you kind of know what to study for the lecture quiz for Thursday, too. But you're also studying hormones. Okay. I would tell you all that I think, how'd y'all feel about that lab quiz today? Felt okay? Look, I actually think that lab quiz, I want to give y'all, no lab quizzes get dropped. Lecture quizzes, I'm going to drop at least 4. And so guess what? Nobody's hurt yet from the lecture quizzes, but you need to get going now, right? All right, and do better now. Everybody listen up. That lab quiz this morning was probably the hardest lab quiz this whole semester. So that's the good news.
That's good news.
Because you thought this morning was awful.
Yeah, because I just drew a blank.
Several lectures on it.
We looked at it and we're like, what is this?
All right, so let me tell you all this. This lab, this directional terms and regions and whatever, this lab is always, not just y'all, this is the lowest lab grade average, class average I have on any labs. I don't really know why. But here's what I want you all to do. That's something else you all should still continue to look at and study, even though you're not, except for this lab quiz you had today, you're not going to have it for me. But you all should be very fluent in discussing these terms. So if you didn't do well, continue to look over it and look at it. Just do it. So it's fine. But it's not going to hurt you too much. It's really not.
Okay, so we're good, we know what's coming? All right, let's go ahead and start hematology, our study of blood. Woo-hoo. You guys, I'll share this. I don't care about me, but when I was going into diagnostic medicine, this was my first clinical rotation was hematology at UVA, and I was like, I'm going to become a hematologist. I love hematology. What could be more fascinating? And I was so fickle that every clinical I went into, no, I changed my mind. I go, no, I want to do this. So the last clinical rotation I went in was microbiology, clinical microbiology. So I think that's just why I ended up in clinical microbiology, because that was the last rotation. That's really not true. I think I would have loved micro the best anyway, but I did start in hematology, and I got hired there, and I worked there my senior year, and I worked weekends there, and I loved it. It's fascinating, and I hope I can just share a little bit of that with you all, because it truly, truly is fascinating, the study of blood, and how much you can know about the overall assessment of a patient by doing what's called a complete blood count, a CBC. CBC stands for a complete blood count. So in a complete blood count, there is a lot of information. You end up getting a red blood cell level, how many red blood cells are there per unit of blood, microliter. But anyway, so you get a red blood cell count. You get a total white blood cell count. But do we know that there are a lot of different kinds of white blood cells? Does everybody know that? Mm-hmm. So not only do you get a total red count and a total white count, you get the white cells broken down, and you get their individual counts. You get a platelet count. You can learn so much from a CBC. You get something that's called a hematocrit, an HCT. An HCT, and I want you all to know what an HCT is, a hematocrit. I want you to realize that when you draw somebody's blood, a hematocrit, if you draw somebody's blood, you told me that you know that blood is mostly extracellular fluid. That's why it's all running. It's liquid, right? And what you call the extracellular fluid? You call it plasma. So a hematocrit, let me tell you what the hematocrit is if you took the whole blood and you spun it down and all the cells went to the bottom, and what was at the top was the plasma. Do y'all see that? A hematocrit is the percent. It is the percent of the whole blood that is cellular. Please don't say it in any other way, because people will turn this around and make it not right. But let me tell you again, the hematocrit is that you know in that person's blood what percent is the cellular part. So that means you also know what percent is the what? The extracellular plasma part. And in most people, more than 50% is what? You with me on that? So why do we care about that? That's one test, just one, an HCT, hematocrit, stands for hematocrit. That's one test of the many tests that you get in a complete blood count. I just told you some of the other things you get in a complete blood count, didn't I? You also get in a complete blood count something called hemoglobin. You get a hemoglobin, HGB level. Does anybody know what hemoglobin is? Yeah. So hemoglobin is that protein part of a red blood cell that carries oxygen and CO2. So you get that level too. One red blood cell, a third of a red blood cell is hemoglobin protein. So that's that major protein inside of our red blood cells that carry the gases. See, that's part of your CBC too. Gosh, CBC, the complete blood count, gives you a lot of different values, doesn't it? Are we going to learn how to interpret those values, do you think? We are.
By the way, a CBC can be done on somebody within 10 minutes of the draw. You can get all that data, all those values in a very short order. So it's vital information. Now I want to go back to the hematocrit for a minute. Y'all told me the hematocrit is if you took this whole blood, you see the blood coming out here, and you spun it down, and you knew the percentage of it that is cellular compared to the whole. Is that right? That's what the hematocrit is. Now, I need you to realize that that hematocrit is important for a lot of different reasons. But one of them is this. You have to understand that most of the cells that are circulating around in your blood, most of the cells are erythrocytes. So what makes up the hematocrit? Look at this. What makes it erythrocytes? What makes up the hematocrit is almost entirely what cell type? Erythrocytes. All right? Erythrocytes. The white cells, white, leuco means white as a prefix, erythro means red, doesn't it? Leuco means white. The leukocytes and the platelets are just a tiny, really a tiny part of the cellular part. And they're going to be actually on top of these red cells when you spin them down. It's called the buffy coat. But they don't really add a significant amount to the hematocrit. The hematocrit is really what? Erythrocytes. All right, now, here's what I want you to realize that this is doing for you. This hematocrit is what we need to understand about it. We said red blood cells are so important because they're delivering gases. They're delivering oxygen to our tissues and then delivering CO2 back to our lungs so that we can breathe it out. Right? All right. So we get that. But maybe y'all can actually also see that when you think about whole blood, you know, when you think about whole blood, that it's the erythrocyte count that is going to contribute the most to the thickness of blood. Do y'all see that? So if somebody doesn't have enough erythrocytes, what did y'all tell me that's called? Anemia. If they don't have enough, if their hematocrit is too low, then that means they don't have enough red cells. Then what do you think how is it going to affect the thickness of the blood? It's going to seem waterier. Is that a word? Thinner, if you will, right? Do y'all get it? But if the hematocrit is too high, then the blood might seem too thin. All right, so I want y'all to write down the word viscosity. Viscosity. Vis with a V, Victor. Viscosity. This is somewhere in your notes, but anyway, viscosity. And that just means thickness. That's what that means, thickness. All right? And I want you to think about something. I want you to think about something. I want you to think about somebody's blood that is too thin. It's too thin. Or somebody's blood that's too thick. And to give you an analogy of it, I wish I had a ball up here, tennis ball. I want you to realize that this blood is never getting to stop at areas. It's constantly moving through your system. If blood slows down, what would happen? If it slowed down too much in your system, what would happen to blood? It would start to clot, right? And so that wouldn't be a good thing, would it? And the pump is pumping blood through the system. The pump is muscle. Just like my throwing arm is a muscle, that's muscle too. If I had a tennis ball, and everybody can imagine a tennis ball viscosity, thickness, and somebody asked me to throw the tennis ball and hit that back wall and not let that tennis ball bounce, do y'all think I could do it pretty readily? It's a tennis ball.
Yes.
Okay. I could do that. I'm really good. A tennis ball. But suppose I had one of those like little ping pong balls or a wiffle ball that was thinner and that it was area. What would I have to do to be able to hit that back wall? Harder. I would really have to throw harder. The muscle would have to work harder. How about if I had a bowling ball? Right? Harder. So, right? I'd have to work a lot harder. So are y'all telling me that the viscosity of blood, which is contributed to most by the red blood cell count, the thickness of blood, the hematocrit, it needs to be within a certain range of what's going to be stressed or the heart. So if blood is too thin, the heart has to work harder. If the blood is too thick, the heart has to work harder. And if it's over a long period of time, can it definitely affect heart health? Yes, it absolutely can. Now, obviously, we see other things that this can affect as well. If somebody's anemic, chronically anemic, what do we say red blood cells are doing? They're carrying oxygen to our tissues. Would this give a systemic kind of compromise to our tissues if you are chronically anemic? Anemia is not a definitive diagnosis. Please understand that. And when I say definitive diagnosis, it means that if somebody says, oh, I'm anemic, that's my diagnosis. Well, no, it's not. That you're telling me that you don't have enough red blood cells. But why don't you? There are a lot of reasons that someone might be anemic. Does anybody know one of the reasons? What'd you say?
Iron deficiency.
You could be iron deficient because it takes iron to make hemoglobin. That's our major protein inside of our red cells. You could be vitamin B deficient. You could have stomach issues, we're going to find out. You could be bleeding somewhere and not know it. How can you be bleeding somewhere and not know it? GI bleeds are so common to be slow bleeds, causing somebody to be slightly anemic. You could have many different reasons, and we're going to talk about them, that's causing your symptom of anemia. So it is not a definitive diagnosis. You would want to figure out why, right? All right, and we want to figure it out because not only would you feel better, right, because you're getting more batteries charged. What do I mean by batteries charged? What do your red cells have to do with ATP formation? Because one of the reactants of aerobic respiration was oxygen coming into our cells. And how does oxygen get to all of our cells? Through their blood, through red blood cells, delivering oxygen to our cells. So absolutely, you're going to feel better if you're not anemic. Your heart's not going to have to work as hard if you're not anemic because of the viscosity. So all of those things play a role. If you are chronically anemic, I want to remind you all of a term that I gave you all called osmolarity. That's under my nose, excuse me. Glad I'm not on video, Julie. Anyway, y'all don't care if I rub my nose, do you? All right, so what did I just say? Oh, osmolarity, right? Osmolarity. What was osmolarity? What's the definition for osmolarity? So knowing the percentage of solids that are in a solution. The percent of solids, now some of the solids here are going to be cells, right? These red cells. And we said that's going to contribute to the thickness of blood. That also makes you understand that you know the percentage of water. That's it, because that's what the solution is water. How did we say water will always move and there's nothing you can do about it? This is the way water moves. It moves down its concentration gradient, right? So what happens if somebody's chronically anemic? It means it's throwing your osmolarity off. And if their osmolarity is off, there's too much water. Water will want to be moving into the tissue spaces. And if water is moving into the tissue spaces, it's going to cause them to become swollen. But what do we call that? Edema. Edema is an excess of fluid in the tissue spaces. So that's going to be throwing that off too. And if you have an excess of fluid in the tissue spaces, it might just be an aesthetic thing, you know, like your feet are puffy or your fingers are puffy or whatever. But it's never a great thing because if there's an excess of fluid in the tissue spaces, is that putting pressure on those cells and those tissues? Yes. And you know, it's one thing to have swollen ankles, but it's another thing to have edema around your lungs. What we call that? Pleural edema. If you have pleural edema, can your lungs change shape the way they need to move air? No. And you know, guys, we're talking now about like a hell in a handbasket when that's happening.
pleural edema. That's a serious thing. And if the edema goes unchecked, can you even get pericardial edema? And can you, which doesn't allow your heart to be able to fill like it's supposed to? And can you even have cerebral edema? So systemic edema, systemic, the system, like having it in your, because of gravity, you can have sometimes edema. You know, you can have occupational systemic edema because you stand long periods of time without moving enough. Moving helps us to move fluid from these extremities. If we have jobs where we're standing long periods of time and not moving and not getting the fluids moving around, we can have sometimes systemic edema. And that's one thing. But if you have these chronic situations that throw osmolarity off, it can lead to pleural edema and even fluid around your heart and cerebral edema. And you know, guys, that's an immediate emergency situation. Those are immediate emergency situations. Yes, Rayon.
What did you say?
What did I say? Anemia was? Edema is an excess of fluid in the tissue spaces. Are your tissue cells and tissues supposed to be bathed in fluid? Yes. Absolutely. They're all bathed in fluid that's constantly being recycled. But if you had too much fluid in those spaces, does that sound like that would be a good thing for your tissues? Y'all have all seen people with swollen ankles, haven't you? They can actually get so bad for such chronic periods of time that people can have what's called pitting edema. Have you seen pitting edema? I've seen pitting edema in patients that are so that's so bad that when you push on like their ankles or their whatever, you can actually lose up to a joint. I mean, don't push so hard. That's not even pushing hard. You can do this, lose up to a joint, pull your finger back, and it stays like that. And sometimes you'll see fluid weeping out of the skin. What's a dam?
That's a day.
Oh, that's right. That's what you think. So, that's not good. My grandmother's like, yeah, and then it can affect the tissue, the skin, and the skin starts to break down. And skin starts to break down, and now you're setting up for infections, and you know, so it can be a serious thing. So, do we need the viscosity and osmolarity of blood being what we need? And what do we know contributes greatly to that? The person's what? Red blood cell count, which is really essentially what test? The ACT, which is called a hematocrit, right? Now, it's not, the two things that contribute most to the thickness of blood is going to be this red cell count. And in plasma is almost all water. What was the key word there? Almost. It's not all water. But it is almost all water. But the major protein in plasma is called albumin. And albumin and your red cell count contribute the most to somebody's viscosity, the thickness of the blood. Okay, so the study of blood, just absolutely, I hope you're going to feel like it's fascinating. I really do hope that you're going to feel that way. And we're going to know that, obviously, is everybody good? If you have any questions, just ask the whole class. So we're going to understand that they're transporting gases, but also in plasma, we have those important stuff like glucose, right? When we eat a meal, is glucose being transported? What do y'all know? We've just finished studying in the endocrine systems. Hormones are being delivered by our bloodstream and the blood plasma. We've got all kinds we have to get rid of waste products, which are just normal waste products that we get rid of, that we're going to be able to get rid of through this. So all of these things are actually happening. You might not think about blood as playing a part in temperature control, but it absolutely does. Water is a great thermoregulator. It's a great way for us to conserve and or get rid of heat when we need to. So when it's really hot outside, what do you see these veins doing? Maybe not mine, but you would see veins dilating so blood comes to the surface, and as water moves into the tissue spaces, you're sweating, right? And it can cool you off, what it's really doing is cooling off these core organs, because your core organs, your visceral organs, have to be within a certain homeostasis for them to be functioning. So you're going to be able to move blood to these extremities. You're going to be sweating and helping to thermoregulate. Where when it's cold, what happens to these vessels and extremities? They constrict and blood gets conserved here in these visceral organs, keeping them warm enough for you to function. Because you know, you don't really need your fingers and toes and the end of your nose. Frostbite will take those. But could you still live as long as your organs are warm enough? And that blood will be diverted to the organs to keep them warm. So thermoregulation is a huge function of blood, something you might not have really even given thought to. So, so we know that if we looked at a blood film, and by the way, you all will be doing your own blood films. Thursday, I'll get you guys to do these. So, I mean, nobody has to stick their finger. I think make people stick. It's just a finger stick. But I do, I don't think I've ever had anybody not, yes, I have. I've had one person not do it. Because most people want to see what their blood looks like and actually evaluate. It's called a blood differential. And I want you all to know this is part of the CBC. This is called a blood differential. Let me tell you why it's called a blood differential. Gosh, there are a lot of tests in that CBC, and that aren't there? There are a lot of test results that you get. And a blood differential, it's called that because you're going to be looking at a slide that has been stained so that certain characteristics of the cells will be apparent to you. A blood film, it's a film. You take a drop of blood and you make a film of it. And it's going to get stained. I'm going to stain y'all so that you can look at it the next time we would come in. But what you're going to see in a blood differential is you're going to be able to look at the red cell anatomy and see if the red cells look like they should be looking. And I'll tell you what's a normal looking red blood cell. These are all kind of normal looking. Do you see why red blood cells are said to be donut shaped? But do they really have a hole in the middle? No. No, obviously not. But they have they do like a little disc, and they get real thin in the middle, so the light on your light compound microscope looks like it's going through it, right? Because they do like this, they're shaped like this. So they have this donut appearance, and that's very normal for them. They are anucleated. What does that mean? No nucleus. So red cells are anucleated. They have no nucleus. A lot of them, you should see if they're all spread out and you're in a good field of view, they will look a little pale in the middle. They shouldn't look too pale, but they'll look a little pale. And then every now and then you will see these cells that have nuclei. You see? These cells that have nuclei. So the cells that are nucleated are white blood cells. Now, I had suggested to you that not all white blood cells are created equal. There's some white blood cells that have a huge old nucleus like this one, and their cytoplasm is really kind of glassy looking, no granules. Some of these white cells are going to have really, really distinct granules. See these distinct purple granules, distinct pink, orangey granules. Some of them have really fine granules with lots of little nucleuses that almost look like they're segmented. Do you see how it looks like this nucleus is segmented? On some lab reports, these are called SETIs for that reason. Most lab reports, they're called neutrophils. But you see, not all white cells look alike, do they? And there are a lot of different kinds of white blood cells. And let me promise you this, for every one of the different types, you will need to know their specific functions. Not just for me, but for your patients, you're going to want to know these. So, because we understand the reason they look different, the reason their anatomy is different, is because they have different blood. So when somebody does a blood differential, of which y'all are going to be able to do your own blood differentials, it's called a blood differential because you are differentiating between the red cells and the white cells, but also mostly you're differentiating between those white cells. And you're getting percentages of each of the different kinds of white blood cells. And hopefully you're going to see in a few minutes why that is so important. Okay? Good? Everybody good? Any questions for me so far?
Is blood already more exciting to you than you thought it might be? I hope that you think it is, because it actually really is. Now platelets, I told you all that platelets are actually, what's the formal name of those cells? They're thrombocytes, right? They're thrombocytes. Okay. So people call them platelets. And we know they play a role, or y'all already know, they play a role in blood clot. And that's really true. So they're going to play a role in blood clotting. And then we said we have leukocytes, of which we have a lot of different kinds. And we said we get that they don't all look alike. These nucleated white blood cells don't all look alike. And let me go ahead and start introducing you then to what they do. Guys, of the white blood cells, leukomet white, of the white blood cells, I'm going to give you some normal ranges that you would need to understand, these normal ranges. I rarely get you to learn lab values just because we have so much other stuff to do. If you understand in the clinical program, you will be needed to know normal values. But in this case, I need for you to know normal values because it helps you to explain how we use them. So of all the white blood cells that are present in an adult's blood, peripheral blood, meaning the blood is circulating, an adult's peripheral blood. And I said adult, which suggests to you what? It's going to be different in children. I want to let you all know that pediatric medicine is a completely different beast than adult medicine. Completely different. Normal values are different. How medicines work in children is completely different. How they're processed in the child's system. Pediatric medicine is a completely, really a different science. It is. So you would always kind of keep that in the back of your mind. This is why if something happens to a pediatric case, you often want to be thinking, do I need a specialist here, a pediatric specialist here? Because maybe we do. If it's not something really standard, then you actually absolutely should call it a pediatric specialist. But what I'm going to give you are normal adult values. Okay, so neutrophils in an adult should be about 65% of the circulating white cells. So about 65% should be neutrophils. That means out of 100 white cells that you see, you would see absolute number 60 to 65 out of that 100 should be these neutrophils. Neutrophils look like these on stains. Y'all's stain is going to be a right stain that looks like this. So they're going to look like this, and they have segmented nuclei, don't they? And at least 60% circulating should be those neutrophils. Now, let me tell you what neutrophils fight against. They're just naturally occurring, they're circulating around, they fight against bacteria. The granules that are inside of them have antimicrobial characteristics, and they fight against bacteria. So why do we need in our blood these cells that are fighting against bacteria? Because blood is sterile.
So it goes to different parts of the body, there's bacteria there.
Blood is theoretically sterile, but if you stub your toe and it's bleeding, if blood is going out, what could be coming in? Some bacteria could be coming in. If you wash your teeth too hard and you whatever, can your gums sometimes bleed? If you bite a hangout and it's bleeding, so every now and then bacteria will enter the system because we live in a world that we're not being kept in little cotton balls, right? And that's okay because we have what? We have neutrophils, and whenever the bacteria would be there, they're not going to be able to grow or anything. They're just going to be taken care of by these neutrophils. I want to tell you about lymphocytes next, because about 20 to 25, no, let me say this, 25 to 30% of an adult circulating white cell should be lymphocytes. should be lymphocytes. Not all lymphocytes are created equal. There's some different special kinds of lymphocytes. Y'all have already heard of some special kind of lymphocytes. What were they? Oh, so you know some of them are T lymphocytes, don't you? But anyway, let me tell you about lymphocytes. Lymphocytes are going to be these cells that are circulating. This is actually a young lymphocyte. This is a mature lymphocyte. So these lymphocytes, they're going to fight viruses and cancer. And about 25 to 30% of an adult circulating blood normally should be lymphocytes. Are we good? All right. The next one I want to tell you about are monocytes. Monocytes are huge cells. They have a huge nucleus that's usually all folded up. You look at the lymphocytes, have a little round nucleus, don't they? Very spheroid nucleus. This has a massive nucleus all folded up. A monocyte. Monocytes aggregate together. They sometimes join together to form macrophages. And let me tell you what monocytes do. They are our dump trucks of our system. What does that mean? They are macrophages. They are big eaters. They're going to clean up debris. They're going to actually help clear out whenever there's damaged cells and things that have happened. They're going to be one of the first lines of defense that are coming to sites when tissues are damaged. You should have normally circulating around about 2 to 8%, 2 to 8% monocytes as an adult. All right, now, there's another type of cell here called eosinophils, and you can have 2 to 4%, 2 to 4% eosinophils. Eosinophils have these huge granules that contain, and you would want to know, histamines. Have you ever heard of histamines? Where have y'all heard of histamines from me? Where have you heard of histamines? Which centers? What?
I don't know.
I didn't
know myself at this point.
All right, that's all right. Histamines, y'all remember from A&P1, y'all said histamines are going to cause vessels to vasodilate. They're going to cause vessels to become leaky. Y'all remember this from me, from A&P1. Can we forget A&P1 just because it's over? No. Histamines cause vasodilation. They increase capillary permeability, which means the vessels are going to become leaky. And they initiate pain receptors. They start pain receptors. So histamines. Y'all have heard of histamines because you've heard of antihistamines, haven't you? When does somebody need one of antihistamine? When they have allergies, and with allergies, you know, you had all this water running. You think, who turned on the faucet? Is that right? And that water's coming because capillaries have gotten big, they've become leaky, water's coming out of these tissues, it's just spilling over, isn't it? Eyes are running, aren't they? Nose is running, you're getting stuffy, you know, it's even beginning to hurt a little bit because, and you got allergies and or parasites, worms. So eosinophils, histamines. Histamines sound like a bad thing. They're not a bad thing. You want those in some situations. You want those things happening in some situations. So 2 to 4% of your circulating cells can be these eosinophils. Less than 1%, less than 1. So out of 100 white cells you see, you might not see a basophil. You might. But if you kept counting another 100, you might not see it. You know, less than 1% are basophils. Let me tell you, a basophil is going to be less than 1% circulating of the white cells, or basophils. They contain histamines too, but they also contain granules that have heparin. Have you heard of heparin? Where have you heard of heparin? With IV. But have you heard like what heparin does? So we can give it as medication. It absolutely slows down blood clotting, doesn't it? So it's an anticoagulant. An anticoagulant. Coagulation means clotting. So an anticoagulant is going to be that it prevents clotting. So these basophils prevent unwanted blood clotting. That would be an important thing, wouldn't it? All right, now let me tell you why I want you to know these percentages. You got this, not that we don't care about adults, but you got this little kid, well, let's talk about adults since I just gave you adult values. You got this adult who comes into you and they're burning up. And they are not well. You're just overall assessment. You didn't even have to do vital signs. You did vital signs, but you almost didn't have to. You knew right away. This is something going south here, and this is really serious. Within 10 minutes, you can get a CBC that gives you these values. And if this person has instead, as an adult, has a neutrophil count of 82%, what do you know you're dealing with? A bacterial infection. If they have, this adult has a lymphocyte count of 45%, what do you know you're dealing with? Viruses. You get what I'm saying? If this person's just feeling kind of punky and not maybe what I just said, just not feeling good, all kinds of head congestion or whatever, and you do CBC and you see eosinophils at like 10%, what have you got? Allergies. You gonna give them an antibiotic?
No.
No.
Is that why allergists do the eosinophil count?
Yes, is exactly why. You can even take a nasal swab and look to see if the white cells, because people will say, oh, they need an antibiotic because it's so much mucus in their nose. Yeah, it's eosinophils. That's what it is. And if it is, then it's allergies. Yes. Or worms. Yes.
What was the percentage against the lymphocyte again?
Lymphocytes for an adult can be like 25 to 30%, and that's normal for an adult. Anything. So we are using the blood differential to help us to diagnose. And is it a definitive diagnosis, or are we just starting on our path to get to the definitive diagnosis? We're just starting on our path, but we can feel pretty comfortable about it, can't we? Because, we might not know what's going on, but guess what does know? The person's immune system knows, and they're putting out what they need. You get what I'm saying? Now, there's also these partial-looking cells that look like little pieces of debris, really, on a slide, almost look like pieces of debris on a slide. You're going to see them. You see these little bits here? By the way, when you're looking at your blood differential, you're going to be fine focusing up and down and up and down. Sometimes they're stained because we know our cells aren't flat. That's why when you get to the magnification you need, you're always, as you're moving your slide around the different fields of view, you're always fine focusing up and down and up and down, because your cells aren't flat, they're three-dimensional. This is giving your brain an idea about how, just what these things are looking like. If there's something that's not in the plane of field of view of your slide, it's just stained debris. But as you're fine focusing up and down, and it is on your film, and it almost looks like debris, but you can tell it's not stained precipitate. It's not that. It's not this trash piece of fiber on the slide. You can see these are platelets. Platelets only live for about 96 hours in peripheral blood. They don't live long because they're from a cell that's blown up called the megakaryocyte. And that cell is blown up. It's just little pieces of cells that are left. But they're endocrine producers. We're going to, before we finish this chapter, you're going to find out hormones that these guys are producing. Just what you need to add to your what list. Huh. But you will be adding to your list. These little guys actually produce hormones. And so they're important. Even though they don't live long, they're really important. And their importance has everything to do with preventing bleeding out. So coagulation, proper blood body, right?
So what happens if you always have a high level of platelets?
The platelet normal counts are between 100 and 400, 450,000 per microliter of blood. So it would depend on what you're telling me is high. Some people have, I'll give you all some prefixes, some suffixes right now, just so you know. If there's a suffix that is penia, P-E-N-I-A, that means low. So leukopenia would mean what? A low white count. What would thrombocytopenia mean? A low platelet count. What would thrombocytosis? This is a different. Cytosis means high. Cytosis means high. So leukocytosis means a high blood count. Thrombocytosis is a high thrombocyte count. Many times, and it depends on the number, because I can't tell you a diagnosis here from just what you said. Many times people can have normal highs and normal than the average, right? But some people can have what's called idiopathic thrombocytopenia, especially the thrombocytes, or idiopathic thrombocytosis. It means they've ruled out anything that's serious that could cause it, and this person just has a slightly high count. So what kind of counts are you talking about? You don't know the count? Is it a patient?
I've seen it. They always come in always have a high platelet count.
But how high? You don't.
I don't know exactly.
They just say it's high. Yeah. So I would actually, want to know how high, because it could just be their normal high, right? But there are some situations that can actually cause low or high, and some of those can actually be serious. Some of them can actually be cancer of the stem cell lines in the red bone marrow. So you rule those things out, and once you rule those out, those situations out, then it might just be idiopathic. So, all right. So, how do you feel? Feel pretty good? All right. So, great.
Let me make sure I haven't missed anything on these new notes. I gave y'all all of those, didn't I? And I gave you what hematocrit means. What does hematocrit mean? It's the percentage of whole blood that is served. Well, and to get the hematocrit, somebody has to do that. So it's the percentage of whole blood that is cellular. All right, so I do want you to know a rough normal for adult female and male. An adult female's, this is just, and I know your textbook would give us slightly different, but to be honest with you, every region has its own normal values for hematocrit because it's based on the population in that region. So like I would dare say Farmville Hospital's normal values are going to be different than even South Boston's. Just, but not a whole lot different, but might be slightly. Do you get what I mean? So I'm going to give you all some rough areas, and you might be made to memorize, and I hope you're not, but I hope you might be made to memorize other types of values too, but they should be close to this, okay? So for a female, an adult female, the normal hematocrit should be somewhere like 36% to maybe even as high as 46% of the blood. That's a significant part of blood that's red blood cells, right? You said 36 to 46% of the whole blood being red cells. Okay, we're saying. Men can have higher than that. Men can actually are typically going to have closer to like 40%, all the way up to maybe even 52%. Why are men's hematocrits higher than women's? And it's not because of what your book says. No, that wouldn't have it. That's a good thought process. No. What causes your red blood cells to be made? Which let's think about this. Which red bone marrow? But what had to target the red bone marrow for you to make red cells? What hormone? Erythropoietin. Where was erythropoietin from? The kidneys. Okay, so we got some study to do.
Yes.
Okay. The kidneys. And the kidneys are monitoring oxygen levels because the kidneys are filtering blood. What a perfect place to be monitoring oxygen levels. Since the kidneys are filtering blood, that's a perfect place to be monitoring oxygen. And what's bringing oxygen? Red cells, right?
So think, and now don't write this down, just imagine this. Imagine your little kidneys. Imagine your little kidneys. You have 4 to 6 liters of blood in your body, depending on your size. But your kidneys filter 150 liters of blood a day. So is blood running through your kidneys at a significant clip? What a perfect place to be monitoring blood oxygen levels. So when blood oxygen levels start to get cut low, the kidneys release erythropoietin, which travels to the red bone marrow to make more red cells. The red cell count goes up and the oxygen levels go up. Do you get that? Do you get that? So the kidneys are doing that. Women have a lower hematocrit typically than men. The major reason is because of men's muscle mass. Men's muscle mass is much greater typically than women's. And their muscle mass is greater because of testosterone. And testosterone is going to increase muscle mass. It's usually going to increase the overall body size and whatnot. And that means that the men are going to need more what? Oxygen. And they're going to have a higher normal hematocrit. Your textbook is going to also say, because women have a menstrual cycle. That is wrong. I mean, women do have a menstrual cycle. That's right. But you should not, do y'all know that your menstrual flow is not from your peripheral blood? Menstrual flow that looks like blood is actually cultivated endometrial tissue and the uterine line. And you're shedding that. It should not be from your peripheral blood. If it were, you are hemorrhaging. And that is not normal. Okay? So that's not a normal thing. If you really truly are anemic because of your menstrual flow, that is something that needs to be addressed. Right? Because that is not normal. That's not what menstrual flow is. You got it with that? All right. So the reason men have higher is because they have testosterone much higher levels than women do, and they have higher muscle mass and all the other things that go along with testosterone, higher body mass, and they're going to need oxygen to those tissues. Muscles require a ton of oxygenation, a ton. So the higher muscle mass needs it. So anyway, hematocrit we talked about. We've gotten a lot of information so far. Do y'all think so? All right. And we said blood plasma, mostly what? Water. But we do understand that of blood plasma, we have proteins. We certainly have proteins and other plasma proteins. Albumin is going to be the most abundant. And by the way, this is contributing to the viscosity and osmolarity that I talked to you about. These are from the liver. So another indicator that someone's liver might not be functioning the way it should is not just blood clotting issues, but also osmolarity issues in the blood, right? So somebody's liver. Globulins are called antibodies, which is what people call globulins. They'll say immunoglobulins, immune globulins. You'll hear immunoglobulins. Immune means what? If you have immunity, you have what? Protection. So when you hear about immunoglobulins or immune globulins, you know that these are proteins that are protecting you. And guess what? They're really what we call them. We call them antibodies. And antibodies are protective. They protect us against foreign antigens. Foreign antigens. Are you good with that? And then there's something in our plasma. It's not just fibrinogen, it's others as well, called clotting factors. Fibrinogen is one of them. These are called blood clotting factors. Whenever you hear the term factor, you can pretty much know it's talking about a protein that's being made. And fibrinogen is one of the blood clotting factors. So we have circulating in our plasma at any given time these blood clotting factors that are going to be ready in case we have a breach in our vessel. Splinter entered, a nail entered, somebody cut you.
you have a breach in your vessel that is going to be ready to help with coagulation, which is blood clotting factors. Now, I want you to realize that blood plasma has these protein types of things, but then blood plasma also has non-protein types of stuff too. Glucose, vitamins, all these nutrients we think about that your cells are going to need brought to them, right? And then also even some gases, believe it or not. Electrolytes, which we said supply the electricity of your body and in your cells, and these proportions have to be just right. So plasma it's mostly water, but it has these great things as well, right? Now, I want you to know, y'all have heard of serology, haven't you? Have you? Yeah, and serology is really a little bit of a misnomer, but not really. I do want you to know the definition for serum. Serology is the study of serum, but it's really the study of more fluids than just serum. But I want you to know the term serum and what it means, because you'll hear that somebody needs to have for a particular test that you need to get not plasma. It's gonna require serum for the testing. So let me tell you what it is. It's plasma minus the blood clotting factors. That's all serum is. It's plasma minus the blood clotting factors that I just told you are more than fibrinogen. There are other clotting factors too. So how do you get serum for a patient? If somebody says that they're going to need serum drawn on that patient, you make sure that when you're drawing it, you draw it into a tube that will clot. You can't draw it into a tube that's not going to clot and think you've got serum. You've got to draw it into a tube that will clot. And actually, you know what the best way to get serum is to just draw it into an empty tube. Because once the blood stops moving, what will it do? It will clot in that tube. And when it clots, it pulls all the clotting factors out. And now that what you have left in that liquid part is serum. Are you with me? Okay. All right. So have you learned anything about, do y'all feel like you got some stuff down in your notes? Huh?
Yes.
All right. So I had just suggested to you that albumin and the red cell count is contributing a ton to the osmolarity of your blood, which is going to tell you how water moves outside of the bloodstream to the tissue spaces, and then even how that would move inside your cells and outside of your cells. So if there is, what would this break down to mean? There's no such thing as big words, right? Nope, you just break them down. And what does this mean? Low protein in the bloodstream. So if somebody has a low amount of protein in the bloodstream, then that means their osmolarity is thrown off, isn't it? The osmolarity's been thrown off. And we can see this sometimes with people with extreme starvation. We said we would also see it when somebody has liver disease, because we said the liver is producing those albumins, which are the most abundant of those. We see it in burn patients because they've lost a certain percentage of their skin, that rules of 9, right? Where they've lost these areas, enough area that they're weeping fluids, including, so it's throwing all this balance off. What did I tell you is the most dangerous thing about burns? What's the most immediate danger about burns? It's hypovolemic shock, isn't it? And so then you're also now worried about this. So this is going to end up causing, you'll see these little, and I say little kids because they always show the really in famine areas, the children that are starving, but they have these swollen bellies, don't they? So they're emaciated because they're using proteins, their muscles for energy. They don't have glycogen because they don't have any meals. So they've lost their glycogen reserves. Now they burn their fats. They have no fat reserves, and now they're burning proteins, their muscles. So they have these muscle wasting, tiny, and the osmolarity is all off. So you'll see these huge it looks like they're all liver and belly. You'll see that. This is kwashiorkor that you've seen with this. And that belly is called ascites. This is referred to as ascites. Okay, all right.
let me see, it seems like I was forgetting something, or maybe not. All right, so here's what. You see what I mean about these red blood cells? These are red blood cells in solution, so they kind of look like they're depressed in the middle. But if you saw them here, this is why the light can just go right through them on your light. But they don't have holes. If they did, they would be, not functioning at that point. So erythrocytes. A really cool thing to think about is that capillary beds, which are the vessels where blood is moving through into your actual tissues. It's the capillary vessels where nutrients are exchanged and water exchange happens at the capillary level. Y'all would want to know at the capillary level. Capillaries are so small. These are microscopic vessels that are so small that red cells have to move through them single file. Imagine that. That's a little bit crazy to think about, isn't it? But they're moving through them single file. And because they're thin, they're one cell layer thick, can nutrients easily diffuse across? Nutrients can diffuse across, waste can diffuse in to be carried. Just passive diffusion. Does it take energy for that? Doesn't take energy. Water's going to move down its gradient. We know we don't have any say about that, don't we? We know water will move down its gradient. When we think about the capillary walls, I told you that there's some things that can make them leakier. What's one thing I told you that would make them leakier? Histamine. I got that, right? So we understand that there's a lot of things influencing how fast these nutrients and solutes and even water is moving, how it's going to happen. But this is usually just passive diffusion, which is actually really nice. Now, do y'all need a quick break before we do it? I'm only going to do about 30 more minutes of notes, but I do want to do this. Do y'all have enough notes for a lecture quiz on hematology? Yes. Okay, we're going to have 30 more minutes after 10 minutes. And then the lab portion today, instead of the lab thing, I would just have available to you if you still wanted to work with those hormones, right? How about the chart? Did y'all look at the chart and do it? So that's what we'll do at 12. But let's take a 10-minute break real quick. Just a 10-minute break. Go walk around some and get things going. Come back, we're going to do a little bit more notes, and then we're going to look at that hormone chart. Make sure y'all are on the right track with that, okay? And then who would want to still play with the concept? Hormones. Is that this concept things, or do y'all have enough of that? It's up to you. Does anybody want to do that? Okay. Somebody mind? Anybody? Yes. Okay, if you do, I'm going to bring them in. Okay, so, okay. 10 minutes.
I have this one that I've cut out.
Oh, you did? Okay, let's leave that one in because I think it's only one person, one group that might be here. I don't think anybody else is going to stay. But I am going to get the chart. Okay?
Question.
Yes, go ahead.
One more on the chart. I can't even tell you what.
Is it the hormone?
Yes.
We're going to do this let me just do about 15, 20 minutes more of lecture, and then we are going to take this chart, and that's what I'm going to do first. And then if people want to go, that's up to you, because everybody's an adult. But if you would want to stay and work, in little groups with this, that's fine too. But you don't have to with these hormones. I would just really, hope that people would. Or a couple people already. So, okay.
Can you go over the capillary vessels again? What you said about them with the erythrocytes? I was
Okay. So, okay. All right. So I think this. I don't know if this will answer. Let me know if it doesn't. So blood, which we know now, all the different components: plasma, red blood cells, all the different white blood cells, and platelets. Blood is moving through vessels in our system. Blood is nourishing every single one of our tissues. Every single tissue you can think of. Think of a tissue. Muscles. No, think of a tissue. Muscles, your liver. I mean, your liver is a tissue. It's got to have nutrients, doesn't it? It gets rid of weight. Your kidneys. How about your heart itself? Is it an organ? It's got to have blood supply coming to the heart itself. I don't mean just the heart pumping blood. I mean the heart itself, right? Your toenails, your hair follicles,
everything has to have these nutrients being delivered to them, and an ability to pick up waste products and take it to areas like the kidneys to get rid of these waste products, right? Where all of the exchange of nutrients and gases happens at the vascular level, that exchange is happening at a capillary vascular level. It's the capillary.
Okay.
Was that the question?
No, that makes sense.
So capillaries are blood vessels.
Right.
So I told you your blood is being pumped around by a pump, right? And as it's being pumped around, there are different kind of vessels we hear about. We hear about arteries, don't we? Large arteries to medium-sized arteries to small arteries, right? But blood can't diffuse nutrients and pick up waste across these big vessels that are really thick. It's being sent into vessels that get smaller and smaller until eventually they're called capillary beds, right? And at the capillary bed level, which is a vascular level, vascular vessels, this is where all nutrients and water is exchanged to the tissues. And then blood continues back to the pump through venules that become small veins, then medium-sized veins, then large veins that get back to the pump. Are you with me on that?
Yes.
So the only thing I introduced to you was the idea that, of course, blood is that liquid connective tissue that's delivering all of these things to all of our tissues. Where that delivery happens is at the capillary level. Okay, you sure you're okay?
Just me.
All right. So we're going to actually break down and talk about these cellular components, because when I talk about the cellular components of blood, we understand that's talking about erythrocytes, leukocytes, or thrombocytes, right? But we're going to talk about all of them even more. But let's talk about red cells right now. I told you that red blood cells are anucleated, and you told me you knew that just breaking down that word means A in front of something means without, right? So anucleate means without a nucleus. Now, they don't start off that way. They don't. But once they get spit out into the bloodstream, that's what they look like. I'm probably going to have to be pissed off. Okay, no, it's okay. So look, it's about, y'all said that erythropoietin is a hormone that the kidneys produce most of it. It travels through the bloodstream to the red bone marrow, and it's going to affect what is actually referred to as I'm going to see if I've got a better slide. I don't, but that's all right. It's going to affect, and I don't care that you even look at these, it's going to affect a cell that we actually call an erythroblast. An erythroblast. It's a stem cell that becomes an erythroblast. And what did I tell you all about what blast means? It means an early immature cell. So if it's an erythroblast, it's an early what cell? It's an early red cell. Now, why did this stem cell, and I don't care that you know that they're this one, but why is this stem cell, why is it going to become an erythrocyte? Because what targeted it? What got there first? Erythropoietin. So erythropoietin gets here first, which dictates what this undifferentiated early cell is going to become. The erythropoietin gets here, the receptors take it in, and then this cell is going to now start to differentiate. And it's going to be an erythroblast that will eventually become a what? Now let me ask you this. As this cell is maturing, it's going to get rid of its nucleus. Because right now, do you think this early immature red cell can actually function by delivering gases yet? No, it would be like saying putting a kindergartner in the OR to do the operation. This is not going to work yet, okay? So do we want it taking up space in our peripheral? Peripheral means circulating, peripheral circulating blood. Do we want really early cells in our peripheral blood taking up space when they're not having a function yet because they're too immature? No. So should we see blasts ever in the bloodstream? No. Not any kind of blast. Not white cell blast, not red blood cell blast. We should not see blast in peripheral blood draws. Do you know what it is when we do see blast in peripheral blood? Would you say? It's cancer. It's cancers, blood cancers. It's if it's other erythrocytic line, it's polycythemia. If it's other white cell line, it's leukemia. So we don't want to see blasts. They're early cells. They don't have their function yet. But as soon as they kind of get mature, are they going to be spit out into the peripheral blood? And look, guys, do you think they're going to live forever? But I want you to know that red cells live circulating around in your system about 120 days. About 120 days. They circulate around, and then they die. But they live, they do an amazing job, and they are going to absolutely do an amazing job. They're made mostly of a protein that we've already talked about. What do we call the protein? We called it what? No. That's a protein from the liver that's in the plasma. Hemoglobin. So it is actually going to be called hemoglobin. God, I do wish I actually had notes that were something. It's going to be called hemoglobin. Can I just not use this? Okay. So hemoglobin. And about 1/3 of a red blood cell is made of hemoglobin. And it's going to just be so efficient because y'all said the little red blood cell is kind of like donut shaped. And that hemoglobin is going to be very close to the surface membrane and the red blood cell. So once hemoglobin has picked up oxygen and it gets to your tissues, oxygen will readily move across the membrane of the red blood cell into the tissues and through the capillary into the tissue spaces. And CO2 will readily move in. And it's just really efficient. That's what it does for about 120 days. Now, when red blood cells break down, because they're old or they're ready to go, that's okay too, because when the red blood cells break down, the hemoglobin can be recycled because you said it's a protein. Now, to make hemoglobin, and it's important to kind of know, the hemoglobin molecule, the heme part of it, has iron that it has to have you have to have enough iron to make hemoglobin. So do you understand then why if you are iron deficient, you can't make enough hemoglobin to fill your red cells? So iron deficiency anemia is a true thing, and it does exist, and it's a very common cause of anemia. It is a very common cause of anemia. It's called iron deficiency anemia. So you do have to have iron. But to make hemoglobin, you also have to have vitamin B complexes as well. So some people, have y'all ever known anybody who gets B12 shots?
Yeah.
How do they feel after their little shots? They feel real good. They feel good. And I usually say it's like little old ladies. But anyway, and they feel a lot better after their B12 shots. Why? Because what do you think goes up after they get their B12 shots? Their oxygen delivery to their tissues, because they're going to be making more hemoglobin, more red cells, and they're going to get more oxygen to their tissues, and they're going to feel a little better. And that's going to be a good thing, right? So some people are vitamin D deficient, and that's why they have anemia.
Vitamin D or
vitamin B complexes, folic acid, vitamin B12 complexes, B12. Did I say D? No, I meant. Okay. And then there's some other nutrients too that you really do need. So do people need a varied diet? Usually typically they say better than even vitamins is if people have varied diets, but most people don't have a varied diet. So taking vitamins might be a good thing. Some of these anemia. Okay. Now, I do want you to know though that
hemoglobin. Part of it is iron, and that's true, the heme part of it, the patient part. But some of it's just the protein part, which is amino acids. So as red cells are getting broken down, your body has the ability to take those amino acids and build new proteins. Your body's kind of a perfect recycling machine that way. And even the iron that gets broken down is going to be recycled. So, your body is great at recycling. All right? Now, I want to let you know something. Because some of you, it's just because it's so common, some of you have been told you're iron deficient and that you have iron deficiency anemia. And you'll have to tell me if you don't want to. But how many of you would like to tell me if you've been told that? So look at that. Look, thank you all for sharing. 1, 2, 3, 4, 5, 6, 7, 8. So look how many people have been told they're iron deficient. All right. So just because you get told that, and you get told to increase the iron in your diet, right? You get told to eat iron-rich foods and maybe even take iron supplements. Did y'all all get told that? The fact is this. The iron, and supposedly iron-rich foods are a much better way to take in iron than any other way. So spinach is, what else has iron? Liver and all those things. But there are a lot of vegetables that actually have iron. So whatever. But here's the thing. If you don't have enough acid in your stomach, you can eat iron-rich foods all day long and you'll never absorb any of it. So you have to have a healthy stomach producing enough acid that it reduces the iron. The iron that comes in is a type of ion, and it has to be reduced so that it can be absorbed. Otherwise, it's going to go right through the other end. You get what I mean? So this helps to explain why some people who have stomach issues are iron deficient, right? Because they're not producing enough iron. It also helps to explain sometimes in our society where everybody's chewing on antacids 24/7. If you're chewing on how many people know people on antacids? If you're taking antacids, it means that you're reducing the acid content in your stomach. So is that going to hinder you from absorbing enough iron? Yes, most likely. And now antacids aren't even prescribed anymore. They're over the counter, aren't they? So that could be an issue. B12, folic acid complexes. You can be taking in a ton of food that has plenty of that, but your stomach produces something, and I want you to know this. Your stomach is producing something called intrinsic factor. Intrinsic factor. Guess what that is? Intrinsic factor. It's a type of what? Hormone. Your stomach's producing intrinsic factor. If your stomach produces intrinsic factor, and it has to escort B12 into your system, in the intestines. So again, you could be eating or supplementing B12 into your stomach, but if your stomach's not producing intrinsic factor, are you going to be absorbing B12? No. So some people are anemic because of that, right? That type of anemia is called pernicious anemia. The B12, not absorbing B12 because you don't make intrinsic factor is called pernicious anemia. Have y'all heard of that? Okay. So again, people who have chronic stomach issues, are you going to watch out for them to be anemic? Yes. Yeah, you're definitely going to watch out for that. And are you going to be aware of just telling them to increase them in their diet isn't necessarily going to happen anyway for them? Because just because you swallow something doesn't mean it's going to be absorbed, does it? Okay, so just keeping that in mind. I have a question.
So if you have GERD that is really bad and you're iron deficiency, what do you do?
So you get a good doctor that is going to help you and help you to monitor what's going on and hopefully try to walk that line that you're not decreasing it too much, and maybe doing even instead of taking so many antacids, doing other things, because they're behavioral things that people can do
for GERD, and GERD is gastroesophageal reflux disorder or disease. But there's some behavioral things you want to be doing even more importantly than reducing acids in your stomach. The behavioral things that you can do is raising your bed a little bit. Have you done that? Have they told you to do that?
Yeah.
Or did you say it's you?
Yeah, it is, Nick.
Okay.
I have it grade C.
So, I mean, there are just a ton of things. Not eating within a certain number of hours before you go to bed, and that includes being very careful what you're drinking at the time. Raising the head of your bed. You know, there's just a ton of, really a ton of
Maybe
different
told me
things.
to eat a bland diet. Yes.
Yeah. So there's a lot of that to do, but high doses of antacids aren't really always the key, aren't the key either, because then that can lead to what we were just talking about. So, okay, so I know I told y'all I wouldn't go long, and I really won't. I just wanted to tell you about a few things here. So these are all different things that could actually lead to anemia. Anemia, again, is not a definitive diagnosis until you figure out why the person is anemic, because they could be hemorrhaging, right? We said, so we talked about that. Now, this is just a classic negative feedback. So it's really mostly your kidneys monitoring the oxygen levels in the bloodstream. And if erythropoietin is secreted to the red bone marrow, and these are regular bones, you're going to get an increased red cell count, and that's going to increase your oxygen. You could actually have hypoxic, you could be hypoxemia or be hypoxic because you're just changed altitudes, or maybe you change your activity levels and you're exercising more or whatever, and then you would definitely, any of these things can actually lead to that. So anyway, and how we get rid of them, this is a reminder from AMP1. You all have had this. So here's your reminder. So as you break down hemoglobin, the red cells in hemoglobin, the heme part is the pigmented part of blood. And I told you all, you can reabsorb these amino acids and reuse them. Same thing with the iron. But then you're going to have this part that's called bilirubin that will build up if your liver's not functioning well. And remember, your liver has to produce enzymes that break down bilirubin to bilirubin and all the way to bile. If you don't break them down, this bilirubin builds up in your system. And the problem with bilirubin in your system is that it's neurotoxic. So if your liver is not functioning to make those enzymes to break down, and by the way, you have not trillions, but you have a lot, millions of red blood cells every day that are 120 days old. So you have a lot every day that are breaking down. And if you're not breaking this down, bilirubin's going to start to build up in your system when I said it's neurotoxic. And you're going to be able to see the side effects of it. The sclera, the whites of the eye become yellow. Your skin can take on this different kind of pigment associated with this. And this is going to be the early signs that your liver is not functioning. Any questions about that? Okay.
I have a question.
And that'll be all we do
Iron. My mom was diagnosed with comatosis. Is that?
So she has too much iron
Yes.
in her system. So that's usually hereditary. And I don't know exactly how that hereditary component happens, but I do know it is hereditary. And that can lead to problems too. And it can be multi-system organ problems. So sometimes what they'll do, what have they done for her?
Honestly, I don't know. They just draw her blood every, I don't know, I think it's gotten a longer time period right now. But she caught it early. I have a lot of family members who have had it.
You have.
That has caught it late, if you will. But because she caught it early, they've just been doing blood draws.
So this is the time, we think sometimes when we hear about people having bleeding done or bloodletting done, that this is like a barbaric, ancient thing. Some people need to have the blood removed. This is a situation where they kind of do, and they'll sometimes do this type of pheresis, where they have these routine times that they're going to actually try to clear this out. Some people have it so severely that they actually are blue. Have you, none of your relatives have it that severely though. And so they try to do that because it can actually lead to a buildup
in some of the organs that can lead to the organs deteriorating. So, but that doesn't mean that's going to happen.
How does it like start? Like, I mean, aside from the genetic component in it, like what kind of triggers it, or is there?
I really don't know. I wouldn't even know. Like, I don't know what some of the earliest signs and symptoms are going to be of it.
Is that something that is found in that text that I'm trying to blank on right now?
Oh, the CBC, the complete blood count. It can be because you can sometimes have one of the signs might be the polycythemia, having too many cells in the bloodstream.
So they would do like a dialysis for that?
And I'll tell you, well, it's not dialysis. Dialysis is typically clearing out the blood plasma. This is actually removing some cellular parts of blood. Part of the CBC, and this is just, nobody needs to write this down, but part of the CBC is something, and some of y'all have seen this, it's called, how many of you have seen CBC reports? On CBC reports, you get something called the NCD, MCHC, MCH. What those things are, what those parts of the test are doing is looking at the percentage of hemoglobin inside the red blood cells. So that's mostly how that's going to be affecting this person's red blood cells. It's going to be inside of the red blood cells. And so I don't know some of what they are doing. I'd be really interested to know what they are doing.
Too much iron, like, because I'm just bear with me for a minute.
And that can affect the liver the most.
It's the liver source building hemoglobin.
Mm-hmm.
It's having too much iron. How does that affect hemoglobin and oxygen delivery and all that?
Yeah, so that's what I'm saying. So they're looking at those MCV, MCHC, because what you'd like to see is that hemoglobin is about a third of your red blood cells. If that percentage gets off, and in this case it would be coming too high, then that's affecting how those red cells function. But also, if the liver has too much iron that it's storing and building up, this can cause sclerosis of the liver, so hardening of the liver, and can lead to liver issues. So I think this is one of those times when they're really, it's sort of like this other polycythemia, where they really will remove. They will do routine removals of this just to try to keep it balanced and consistent. Some people being more serious than others. Is that different blood? I don't think it necessarily is going to be thickening the blood. It's just affecting how, I mean, it can, but it's just affecting how it is. So I don't know enough about it to tell you how to go about treating it.
One more thing. So that blood that's drawn from that can't be used for other people, like as a donation or whatever.
Yeah, no, they're not going to do that. But I want to start on this next, when I come back in here Thursday, I would like to talk about how people donate blood and what happens with the units. How many of you donated blood? A bunch of you. So I want to start with that and how people use the different components. Almost never, unless you're doing your own blood, storing your own blood for like a surgery and then that short period of time, whole blood is never donated. I mean, you donate whole blood, but it's not given as whole blood. They're going to separate it out, and they're going to give components, right? Yeah. So I'll start with that, and I'm sorry I can't answer more questions about it. I just don't know enough. It's a fairly unusual, condition, but I did know it's inherited. It's an inherited condition, and I know some people, they actually have a routine of blood letting, of getting the blood out of the system.
I have a question about osmolarity. Okay, osmolarity is in the slide, just while questioning. If it's too high, like if it's too much, the blood absorbs too much water, causing like a high blood pressure.
High blood pressure.
But that goes like against the hormones, right? Because if you hold too much water, it decreases, right? And maybe I'm confusing myself.
I don't know where it is.
Oh,
there it is. Okay, all right, look. Okay.
Like if you have edema in here, it says if it's edema, then your blood pressure is down.
Because water has lost from your bloodstream into your tissue spaces. So if it's going from your bloodstream, water is moving from your bloodstream into your tissue spaces, blood volume is going down. So blood pressure is going down. But if water is staying, if your osmolarity is low,
which means, or now I'm getting confused, if osmolarity is high, and so now water's staying in your bloodstream, that's bringing your blood pressure up. Does that make sense?
I'm just confused myself. I think I'm just going off it.
What were you saying about
So
the
if you have
hormones?
a low osmolarity.
Okay, so
edema
remember,
occurs.
osmolarity is the percent of solids that are in the solution. So if you have a low osmolarity, it means that in your blood there's a lot of water. So water's going to move into the tissue spaces. Right. That means blood volume's going to go down, and blood pressure's going to go down. Is that right? But if you have a high osmolarity, water will move from the tissue spaces back into the bloodstream through the capillaries. They will move back in. What's that going to do to blood volume? Increase it. What's that going to do to blood pressure? Increase it.
What were you saying about the hormones? You said something about hormones.
Because I might add.
Now, how that's just a separate thing that's happening.
Yeah, that's what.
That's just a separate thing that's happening. But okay, so you actually bring up, and I won't spend a lot of time because I know y'all are like, oh God, just move on. But look, you know, so this sort of brings up something else. You know, we have a lot of hormones that end up helping us to bring up blood pressure. Because don't be thinking that high blood pressure is always a bad thing. Actually, it's not. Having a low blood pressure, if it's too low, is called what? Hypovolemic shock. And shock is dangerously low blood pressure. So we have a lot of mechanisms that help to bring up blood pressure. So don't always be thinking it's a bad thing. And all of these things are all working in unison. They're all working in unison.
I think I was just thinking.
So if blood pressure is going up, we also know that we have like A and F that can help it to go back down if your heart's functioning.
I think I was just thinking about the anti-diabetic. It was holding the water and the blood pressure goes up. But in this is opposite. Does that make sense?
But there are a lot of things that are opposite and or synergistic.
Yeah,
right?
That's where I was.
So guys, let's quickly go, or not quickly, but let's go over this. Does everybody have their copy? Does anybody need a copy? I have a lecture. So everybody's got their copy of this chart out. Did people get to look at it? All right. So look, guys, here's what I would definitely recommend not doing. I would recommend not using this as a study guide. Why?
Because it doesn't have all the hormones.
No, it's not.
Because there's no organization on this. This is just you testing yourself. You know what I'm saying? This is you testing yourself. But this is like really, scrambled. This is you testing your knowledge. But a way to study would be using this, but organizing it. So making sure that you have all the pituitary hormones here. Then I would highlight them the same color. Have all the thyroid hormones next, maybe highlighted a different color. You know what I'm saying? I would organize something like this to study guide. I wouldn't use this to study guide. This is just you testing your knowledge. If you don't know this well or couldn't do this well, it means go back and study. Right? Okay. But let's look at it. So on the first line, you have the only thing you're given is the pituitary, and then you're given that it's going to conserve water and raise blood pressure. Well, which one do you know from the pituitary does that? ADH, and where does ADH target? So you were able to fill that in, right? This is like your goal setting, how you want to become, right? Okay, you would want to be able to do this rather readily. The second line, the only thing you're given is prolactin. Do you know where it's from?
Pituitary.
Do you know what it targets?
The mammary.
And do you know what its function is?
No.
All right. Do you know what it does in men? If I had had its function is to increase sensitivity to LH, you would have known that this was in men, right? So okay, right. And the next one, you only have one blank, but you're looking at it. You know it's going to be a hormone from the pituitary. You know that it's targeting ovaries and testes, and this is telling you that in the ovaries it's going to function by stimulating ovulation. And in the testes, it's going to increase testosterone production. So what is that hormone? It's luteinizing hormone.
But you skipped oxytocin with the ejecting note.
Oh, I did. Okay. Okay. So I skipped one, so please let's go back. I'm sorry. So pituitary, mammary, and ejecting milk is oxytocin. Thank you. Thank you. Y'all keep me honest here. The next one is FSH, follicle stimulating hormone. Where's it from? Pituitary. And in the ovaries, what does it do? Pituitary. And in the testes, what does it do? Pituitary. Great. The next one says oxytocin. Oh, we've already had that one, but here, this is saying the uterus, targeting the uterus. Where's oxytocin from first? And what does it do when it gets to the uterus? Exactly. Contracts the uterus to expel the fetus. That's exactly right. Exactly. So it's contracting, it targets the myometrium, the muscle part of the uterus, to contract, to expel the fetus. The next one, you were given pituitary, and you were given that a function is to increase metabolism. So that would be thyroid stimulating hormone, and where does it target? Thyroid. And metabolism should go up. Y'all like that? All right. The next one was growth hormone. Where's it from?
Skipped one.
Oh, I did. Dang. All right, look. All right, sorry guys. All right, I skipped one. The next one, you got a lot of things. You got the thyroid. You got that it targets the kidneys and bone, and you got that it decreases blood calcium levels. You like that? Calcitonin? Yeah, that's right. Calcitonin. The next one was growth hormone. Where's it from? Pituitary. And it targets the liver first, and then the liver produces somatomutins, and then they target all the cells. And what's going to be the function? Growth and tissue repair. Growth, tissue repair, protein synthesis, all those things. Absolutely. Regeneration. Great. The next one, you got a lot of stuff. Adrenal glands. You got many cells, and you got fight or flight response. Norepinephrine. Exactly. Epinephrine. So,
Looking at that class is the
catecholamine.
Yeah.
is that right?
Yeah, that's fine. But
Okay.
y'all know what catecholamines are. Epi, norepinephrine, and those right. All right, so the next one, the only thing you could, well, no, you got two things. You got aldosterone, and then you got a function about electrolyte balance. Where's the aldosterone from? Adrenal glands. And what does it target? Kidneys. And what does it actually do? It causes you to bring in sodium, but expel potassium. But when sodium comes in, is that going to conserve water? And is that going to raise blood pressure too, isn't it? Yeah, good. This chart was for fun. I've used this chart as a quiz before. Would y'all have been ready for this quiz? Yes. So here's so there's your sign, and I mean that in the nicest of ways. But there's your sign. So it means that it's good to spend more time with these. But you go T3 and T4. What do they stand for? T3. Trial.
We're tripping over this. Thyroxine and triiodine. There you go. Close. Can you say that, please?
Triiodotyrosine and thyroxine. And the 3 and the 4 stand for how many atoms of iodine. And where are they from? The thyroid. And they target many cells throughout the body. And what will the cells get a message to do? Increase production, increase metabolism, right? All right, the next one will shoot. You only got one thing. You got the target. That's crazy. You got T lymphocytes. What do y'all know targets T lymphocytes? Where are they from? And what's the function of those T lymphocytes? It's protection, isn't it? It's immunity and protection, part of your immune system. The next one was the pancreas. And you have to look, because you know the pancreas secretes several things, but this one says increased blood glucose. Glucagon.
But alpha cells, that's wrong because that secretes, right? That secretes the glucagon.
It's the pancreas.
No,
Pancreatic.
for the hormone part.
So the hormone is glucagon. Alpha cells aren't hormones.
But it does secrete those, right?
It secretes glucagon.
From
Alpha cells of the pancreas. The
okay.
pancreas
So
has
they're-
different cell types.
I missed that part.
Okay, the pancreas, if we were to do a dissection of the pancreas gland, it has different kind of cells in the pancreas. And so the alpha cells secrete glucagon. The beta islet cells secrete insulin.
That's what threw me off because I was
The
reading
alpha
the book and
cells
I couldn't
secrete
find
somatostatin.
what
But you know, yeah, so
So the alpha and beta cells are
they're
sections,
They're
sections within the
cells.
pancreas that secrete those hormones.
Right.
Gotcha.
Remember that hormones are molecules. They're signaling molecules that cells produce, right? So yeah, absolutely. So in looking at that line, something that says increased blood glucose, I'm thinking glucagon, and they are the pancreatic alpha cells, but you just need to know pancreas for this one. And it targets what? The liver, what in the liver muscle does it target?
Stored glycogen.
Glycogen, stored glycogen in the liver and the muscles. The stored glycogen, because what do we know glycogen really is a molecule of?
Stored
Glycogen is just glucose molecules that have been made into this glycogen storage form, right? Is that good, guys? We're not confusing anybody, are we? All right. So the next one just says the only thing we did is A and F. Do we know what it stands for? Good. Atrial natriuretic factor. It tells us in its name. I love it when in its name it sometimes tells us where it's from or where it's targeting. In this case, it tells us where it's from. Atrial. Where is it from? Heart. Natriuretic means natrium is sodium, so it's going to have something to do with sodium, isn't it? Where does it target? Kidneys. And what's its function? It's to expel sodium, so water's going to follow it, and blood volume's going to go down, and blood pressure's going to go down. Are we good?
Would we be all right to say that it lowers blood pressure? Like that's a function?
That is the function. I was just telling you how. But that is the function.
I just want to make sure I write the right answer on
Right. But these are for you. These are telling you, but these are for you. I've just given you more than what you would have maybe even, but certainly what you know the function is to lower blood pressure. That is the function. All right, the next one says liver, and it says blood clotting. What do we know from the liver? Thrombopoietin, and where does it target? The red bone marrow, stem cells in the red bone marrow. And then those stem cells are going to become platelets. And it's going to help with blood clotting. The next one, the only thing you get is cortisol.
That's in the wrong spot.
It's in the wrong spot. It is.
Yeah.
Did y'all move it?
Yes.
Yeah. Okay, thank you. And where's it from?
Adrenal.
Thanks for picking up on that. So the adrenals, and then where does it target? Widespread, and it's for tissue repair. Good. The next one just tells you that it's something that lowers blood glucose levels. Insulin. Where is it from?
Pancreas.
Now, this is one you sometimes get asked where in the pancreas. And you know why you get asked about this one? You get asked, and this is one that they do want to know the beta islet cells, the beta cells in the pancreas, because type 1 diabetes mellitus is what kind of a disease?
When the beta cells are getting attacked.
When it's an autoimmune disease that attacks the beta islet cells. And you'll hear about that. And so they do want you to know insulin is from the beta islet cells of the pancreas. And and insulin's going to target glucose molecules to escort them into cells
and it's going to lower blood glucose levels. Insulin also targets those glucose to form what? For storage, glycogen. Insulin targets glucose to form glycogen that then moves to the liver and muscles for storage, right? How are y'all feeling? Any questions about that? Right, the testes, and its function is going to be muscle mass, beard, hair, secondary sexual characteristics, and that is going to be what? Testosterone, and really testosterone is effect for widespread effects, including sperm production. So it's just widespread effects, isn't it? The next one says erythropoietin. Where do I want you all to know that's from?
Kidneys.
Kidneys. And where does it target? Red bone marrow stem cells. And what does it do? It increases blood oxygen levels. And it does that by making the stem cells. It increases your oxygen perfusion. And it does it by increasing red cell counts. Right? So this is just an exercise for you to sort of feel like, okay, I got some more work to do, or feel like I'm okay, I'm on the right track, right? Because you should be able to be asked, this shows you that you should be able to be asked, what does this organ secrete? Or you should be able to be asked, this is the function, what hormones needed for that? Where's that hormone from? And how does that hormone do that? Y'all have, hi guys. I get it. You know, I had warned y'all though, hadn't I? Had I warned y'all about this hormone? That doesn't make you feel better, does it? What can I do to help you? Seriously, yeah. What can I do to help you all? And you can't say that, you know, just not give you assessments on it. Because that's not going to do that. I have to do that. But what could I seriously do to maybe help you all better? You know, anybody have anything that's really, has anybody in here had to change the way they study from a typical class? Is there something you found that you've changed to, like some sort of strategy that you feel like, oh my God, which I know I did this before, that you want to share with people, because maybe somebody else can try it?
Well, I never talk that.
You've never talked out loud?
Same.
I used to just try to remember.
Just try to look at it and look at it and look at it.
Or sometimes I'm trying to like teach it.
Yeah, like you'll.
I'll be like talking to my mom, like teaching.
I have a lot of students who tell me that they try to start talking to a parent, or a mom or dad, or a husband. I've had some students say, my husband hates you because, you know, all I really have. I have had students tell me that. I was like, so that's where so either just talking about to yourself, or if you have somebody that would put up with you do it. Would you say?
Rewriting notes.
Rewriting your notes?
Yeah,
listening to the lecture. Re-listening.
Yeah.
So people who re-listen.
I actually listen to your lectures on the way here because I have like an hour drive.
Yeah.
So like I get an hour's worth of another lecture of what you've already done. So I split like the lectures in half.
Yeah. So some people are real audio learners and that can really help them. And so that's great if that's working. So all those things y'all just said are proven ways to help you that you've maybe never really had to do in another class. But this type of class really does require that. I mean, it kind of requires you moving out and figuring out other things. And sometimes when you're first doing this, it's going to take longer for you to get those strategies going. But after you practice them a while, you'll realize that they work better and you spend actually less time because it's effective time. You get what I mean? Than just kind of like looking at it.
I wish I had your class before I went to elementary school because I failed the hormone test, and then going back through it now, it's just like,
oh my God,
it makes sense.
Yeah,
like,
yeah.
that way. So regulate your class.
Well, y'all have probably all heard, and I have PNs, I have nurses in here and PNPs and paramedics and stuff. So y'all have all heard that in an RN thing, which is the most difficult undergraduate degree to get. Y'all have all heard that the hardest part is med surg. Have you heard that? Mm-hmm. Guess what med surg is? A&P. And if you're trying, and here's the thing about med surg, y'all have all heard that, right?
I've not heard that.
Okay, well that's all it
Really?
is. That's all it is. So, well, that's why they fell out of it, because when they're in med surg, the hardest part, they're expected to know this. And then they're having to learn nursing procedures, which are a lot of like what to do first, what to do fifth, what to do eighth. You know what I mean? Or the nursing, or if this happens, then do this. If this, then. If this, then. Right? So nursing procedures, and you can say I said this. I think I'm so being recorded. Maybe I should turn it off. No. There's nothing about nursing procedures that are hard. They're not hard. They're like just learning what to do if this happens then. But if you don't know the reasoning behind it, that can become incredibly hard because you're still trying to do what with those procedures? You're trying to memorize them, and bless your little hearts, it's not going to be able to happen. So please, the difficult part of medicine is truly physiology. So make sure you know that, and then when you get to the nursing procedures, if this happens, then, if this result you find, you'll do what next? All of that's in place so that those steps make perfect logical sense. And it's not memorized. Because where do mistakes happen in medicine? When people have what?
Just memorize.
When people have memorized. That's where mistakes happen in medicine. And it's the one field that no mistakes are allowed. I mean, I say that with tongue in cheek because obviously that's just ridiculous that people don't expect that there are going to be mistakes made. Mistakes will be made, but not even just mistakes. But there shouldn't be like gross errors. Gross errors happen because people have memorized and not learned. That's why I just try to say as much as I can to you all, stop memorizing. You are not critical thinkers if you are memorizing. Talk it out. Teach it to somebody, like Alexis says she's doing. You too, Kelly, said you teach it, or was that Alexis? You were typing it, but Alexis said you teach it to somebody, because if you did, you will own it. You will own it. And then learning those procedures, you're not having to learn the A&P part and the procedures. You know, what'd you say?
That's so awesome. I didn't know that was what it sort of was.
It is. That's what it is. So
Pretty
you've got somebody you've got somebody who is hemorrhaging, and you'll be given, but you'll want to know what's going on. Or you've got somebody whose osmolarity is off, but you're going to know what that means. So, or you've got, you're just going to be hearing about those things. So you got somebody who's hypertensive, so you've given them a diuretic and a beta blocker, which is going to affect the angiotensin. It's going to inhibit the angiotensin. So you already know that part. Now you're just thinking about, okay, I'm going to do this, 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 in these order, in this step. So, okay, guys, I don't know how I can help you, but those things, y'all just help each other by saying what's helped you all. I usually, it's really sad. It's usually around the end of the second semester that people are thinking, okay, I've figured out how to study now. See ya, because we're done. But it should help you going forward, right? It should help you going forward. All right. Well, if y'all want to do that concept thing, you can. If you don't, if you want to go on, it's fine too. Whatever.
Okay, some of them either it's too much.